Hi, my name is Marla O'Keefe. Thank you all for being patient with this brief delay. Today's workshop is Your Mouth and Chronic Graft-versus-Host Disease. I'd like to thank Kadmon, a Sanofi company, whose support helped make this workshop possible. It is my pleasure to introduce Dr. Vigneswaran. Dr. Vigneswaran is a professor of oral and maxillofacial pathology at the UTHealth School of Dentistry in Houston. He specializes in the diagnosis and treatment of oral mucosal and salivary gland and jawbone diseases. Please join me in welcoming Dr. Vigneswaran.
Thank you, Marla. Thank you all for waiting. I'm sorry for the mishap, the timing, and we'll get through that very quickly, and I'll be happy to answer if you have any questions. First of all, thank you for the InfoNet to inviting me to give this presentation. And I've been working with the MD Anderson Clinic with a number of patients with GVHD, and I hope I can answer some of your questions. If I don't know the answer, and I will ask other experts and get back to you all. So with that introduction, I want to start my presentation. And so as you can see from chronic GVHD, the most common area that in our body that is affected are skin. The second most common site, about 60% of the patients with chronic GVHD their mouth get affected. But most of the mouth issues are very minor most of the time, but occasionally it can be most severe pain and other complications. So we are going to go through some of the common as well as some of the rare but more serious complications that can be seen in patients with GVHD patients. Next slide. So that the second most common site that affected by GVHD is the mouth. So that's what we are going to talk about. So what are the common problem patients with chronic GVHD encounter in the mouth? Typically, they will feel pains, ulcerations, or sores. They will explain that's painful, especially while eating some crunchy food or hot or spicy food bothers them, or even in the throat they can have in the mouth. And frequently, they also have chapped lips, like a cracking and dry lips, of course, dry mouth, and that connects with the dry. When you have a dry mouth, that increases the risk of developing decay of the teeth. And infection is frequently seen. We're going to talk about some of the common infection that we can see, and most of you might have a prophylactically treated for antiviral and antifungal, but there are some infection may overcome that and you may present. And the last topic I'm going to talk about, the risk of oral cancer, is slightly increased than the general population. So what are the problems that are commonly seen in patients with the chronic GVHD? Frequently, we see some of the infection commonly seen are the fungal infection. We call them yeast or thrush. Sometimes thrush can look like a red or white. And of course, viral infections, commonly the herpes simplex virus or herpes zoster virus, rare. And most of the patients are basically on antifungal prophylactics and antivirals. So usually you won't see that, but if they stop the treatment, antiviral or antifungal, then these can end up coming back because of the immunosuppressed status of the patient. The most very common condition that we see in patients with GVHDs, we call them oral lichen planus or Lycanoid changes. What that means, there is a very common condition we see in non-GVHD patients in the general population, a condition we call them lichen planus, which is a very kind of a red and white patch of striations. And the similar lesion also occurs more frequently in patients who had bone marrow transplant patients. And that's what we call them Lycanoid. They exactly look the same, even microscopically in the biopsy, they look the same, but the only difference is in patients with GVHD, that is bone marrow transplant triggers, that is somebody else's immune cells attacking the mouth, whereas in general population, that is their own immune cells. So they are called autoimmune. In the case of GVHD, it's called allergen or kind of a graft-versus-host disease. The common other problem sometimes is very minor matter is hairy or coated tongue. I'm going to show you a lot of pictures, so that will make. And frequently also we see the gingival inflammation, what we call gingivitis. As you know, gingivitis most commonly caused by bacterial gingivitis or plaque-related. But in some patients with GVHD, they develop gingivitis due to GVHD, immune, and that's what we call them desquamative gingivitis, so which is not plaque-related. It's by brushing it, keeping your mouth, still the gum is going to be inflamed, and we'll talk about it, what's the treatment for that. And the last one is the dry mouth is another common complication because of the GVHD affecting your salivary glands or medication that you would be taking that can also cause dry mouth. Okay. So this is different types of the lichen planus, and I'm going to show you the picture, so I'm going to skip that and going to go straight to the pictures. So these are the pictures of what we call this is a very common lesion that we see in patients with chronic GVHD affecting the oral cavity. So we call them Lycanoid keratosis. What is keratosis? An increase, almost like a callus-like white patches occurring in the lips, in the tongue, or in the cheek. And in the top of your tongue, it will be more like a white plaque like that. Fortunately, these lesions, these white areas, are rarely causes pain, or unless they are mixed with the red areas. So these are called Lycanoid keratosis. And frequently, if they are not hurting or if they're not painful, if you're not feeling any pain while eating spicy or acidic food, we just leave it alone. We don't treat that because it's not causing pain, because we cannot cure it. And with time, they will become less and less prominent and become not cosmetically bothersome. So unless if it is painful, we do not treat these conditions called Lycanoid keratosis. The pain and sensitivity comes with these type of same Lycanoid mucositis. This is, we call them mucositis because there is definitely inflammation and thinning of the epithelium. So that's where the skin of your mouth becomes very thin and inflamed, so that looks red with some white patches like that in the tongue. On the top of the tongue will be very smooth and red, and side of the tongue will have white patches with redness. And these patients will have very, very sensitivity for spicy food, hot food, or even a crunchy food will be bothersome. So this is what we call Lycanoid mucositis. Again, these patients with this condition may need to be treated, and we'll come back to that in a minute. What is the treatment we usually prescribe for these patients? And the form of Lycanoid mucositis, these type of lesions. These are called ulcerated. These are the worst ones. They are the most painful. So you have an open source like that. You will have a kind of a yellowish dead tissue in the middle, large areas either in the cheek or in the tongue. And in patients with GVHD, because of the immunosuppressed condition, and these can get secondarily infected by bacterial infection. And bacterial infection, some of the bacterial antibiotics that your doctors will be prescribing you, like a Bactrim, and those antibiotics will not protect against oral bacteria. So in that instance, we sometimes have to treat you with amoxicillin or some antibiotics that will work for the oral microbial flora. So when you have a very large open sore, when you have a dry mouth, and every one of us have bacteria in our mouth. We cannot get rid of it. That is normal microbial flora. But when patients undergo GVHD, stays in the hospital for a long term, that the microbial flora changes. Some bad bacteria get in your mouth too. So those bacteria utilize the opportunity being immunosuppressed. Maybe you may be taking prednisolone or some of the other immunosuppressive medications like etacolim or sirolimus. So those bacteria can overgrow and get rid of the good bacteria, and then you have an open source, then they become secondarily infected. I'll show you pictures in a minute. So that's to keep in mind. And in these bacterial infections will not clear with the Bactrim that your doctors will be prescribing for your GI or other, those are called gram-negative bacteria. Most of the bacterial infection that occurs in the mouth is called gram-positive. So important to keep in mind, maybe you are taking antibiotics, but that antibiotics may not work for that. Another thing that sometimes you may see, especially in people with darker skin individuals, these inflammatory lycanoid lesions can become pigmented. So you may see some grayish or blackish discoloration in addition to red and white areas. That is the normal response of the body. When we have a dark skin individuals, when there is an irritation and inflammation, it's like you go to the sun, you make more tanning. In the same way, an inflammation makes the mucosa to become more darkened. That is we call them post-inflammatory melanosis or pigmentation. That is the normal response. It is not a melanoma or anything like that. That is typically occurs in dark skin individuals with long-standing inflammation. The inflammation is coming from the GVHD or Lycanoid mucus condition. So how do we manage that? So this is a very common condition. As I said, when you have white areas, no pain, we just leave it alone. But if you have a pain, depending on the severity of the pain and extent of the lesion, we start with the very conservative methods using a topical corticosteroid like clobetasol gel. Always use the gel medication. Usually in the mouth, do not use anything with like a cream or ointment because mouth has saliva, it's watery. So you want to use the gel that will spread, that can apply to the mucosa. Or cream doesn't spread out. So the gel is the best form to treat in the oral lesions. Another thing to keep in mind, when you buy these tubes of gel, it is going to state it's in external use only. The reason is the FDA has not approved any topical corticosteroid to be used in the mouth. But remember, mouth mucosa is similar to skin. As far as you don't unnecessarily swallow your spit, you can apply these to the mouth mucosa. Since it's kind of an off-label use, or FDA has stated that this can be used in the mouth, so you are going to say that you're going to see it in the tube as an external use only, but you can use it in the mouth. But when you're putting it, if you have a spit, do not swallow the spit. Try to spit it out or take a paper towel and wipe it away so that you don't. If you swallow it, it's not poisonous or anything like that because unnecessarily you're taking systemic steroids if that's not what your doctors meant when they prescribed the topical ones. So it is either clobetasol, which is more stronger, fluosinide gel is a little intermediate, so either one depending on how extensive the disease is. The other ones that usually, if you have a lot of areas affected, like a cheek, tongue, and other places, it's very hard to put the gel in topically. So we can prescribe rinse form, which is typically most common one that we use is dexamethasone, as you might have heard. So you would use that, just put it in your mouth, 1 teaspoon, keep it as long as minimum 2 minutes, maximum 5 minutes, kind of move it around the areas, then you are going to spit it out. After you're spitting it out, do not go immediately rinse your mouth. Leave it at least 15 minutes, 10 to 15 minutes longer, and after that you can rinse your mouth out and you go on with your life. So make sure not to rinse immediately. Keep long as possible in that day. If you have a large ulcer like the one that I showed earlier in the tongue, in order to make them heal faster, we sometimes give intralesional canalog steroid injection. What it does is rather than giving you systemic medication, which has its own side effects, by giving straight away around the ulcer, that will help the ulcers to heal faster. So if you have one deep ulcer like that, or even 2 of them, we can do under the local anesthesia. We'll inject it around the ulcer. That makes the ulcers to heal faster. If there is a severe condition and it's not responding to the other treatment we just talked about, and that's where we're going to start the systemic steroids. Sometimes doctors will prescribe prednisolone, or I prefer dexamethasone, Swiss and Solo in that reason because it has a topical effect as well as systemic effect. And so that's where we would use a tapering dose. That means rather than we'll start with the higher dose and slowly gradually reducing, and we need to reduce it very gradually, every week, slowly, and not typically the metro dose pack. I like to use it for longer term to get your immune system kind of tame it down so that it slowly stops attacking your mouth. But sometimes your doctors might say you have other complications, you have thinning of the bone, osteoporosis, you have other conditions that they do not want to use steroids systemically. There are other options like a steroid sparing medication such as tacrolimus cream, or sometimes you're going to make an oral solution out of the capsule so you can rinse it and spit it out. So that because that same capsule you'll be using for your GVHD, we make it as a solution, and you can use it to rinse your mouth and spit it out as a topical treatment. There is a cream also available. There is an ointment available. Unfortunately, they don't make gel for tacrolimus, so that's the reason I don't like to use it as a gel. I will compound that as a solution and use it for that purpose for the mouth. Okay. So one other thing to keep in mind, like if your doctors prescribe a prednisolone or dexamethasone or even a rinse and spit it out, and if you are not taking any antifungal medication, posaconazole or diflucan, if you are not taking any of them, you may have a risk of developing yeast infection because the steroids suppress your immune system in your mouth. So that's because like bacteria, we also have yeast in there, but it doesn't cause infection. It lives in our mouth. But as soon as we suppress the immune system, then it's going to cause thrush or yeast infection. So make sure that if you're taking antifungal, then you wouldn't have the problem. If you're not, and if you started taking prednisolone or any immunosuppressive medication, you have a greater likelihood of developing yeast infection, thrush. So you may think, oh, this is due to my GVHD, but that may not be the cause. And I will show you some examples in a minute, pictures in a minute. So keep in mind, if you're not taking antifungal prophylactic, you started taking systemic steroids or frequently using oral rinse with steroids, that's to keep in mind. So here is another common mistake a lot of patients make. So here you are seeing on the two areas, the top of the tongue looks white, and other one looks like a brownish white. These are, we call them hairy or coated tongue. It occurs in both non-GVHD patients as well as GVHD patients, but we see them frequently in GVHD patients. The reason being of the one is dry mouth, so because of our saliva keeps our mucosa to be healthy and kind of cleaned up. When you have a dry mouth and some altered microbial flora, which I talked about earlier, that irritate the top of the tongue and make those, we call them filiform papilla, to grow a little higher and then get coated by bacteria, and that's what it's dark white. So a lot of time, not only patients, even the medical doctors mistake this as a thrush. Remember, this is not thrush. This is actually a bacterial coating of your dorsal tongue. Especially a thrush or yeast infection, when it occurs in the dorsal tongue, it will look more red. I'll show you pictures in a minute. So if you have a tongue like that, this is called coated tongue, and I'll explain to you how you treat that in a minute. And sometimes it also can get pigmented by if you're drinking coffee or certain medications, or certain bacteria can make chromogenic substrate or chromogenic, and then they become more blackish or white. And this can also cause some malodor, halitosis, and also can cause some irritation in your throat when you swallow. So these are some of the complications that you can see that. But it's very benign condition, and it can be easily taken care of, and I will come back to that in a minute. So it is typically of the top of the tongue look white or the brownish or blackish. So sometimes rarely it can cause halitosis, it can cause cosmetically look ugly, but in rarely it also can cause irritation or gagging sensation in your throat, can cause some altered taste in your mouth, and always make your mouth feel very dry. That is the kind of a primary factor, as well as secondarily by having a coated tongue, make it more, your mouth feel more dry. Okay. So who gets it? And it's only, it occurs in both non-GVHD patients and both GVHD patients. The major risk factor for developing is typically, as I mentioned, dry mouth. and severely ill patient, which some of you are because you had a bone marrow transplant, you had a lot of medications given to that, and that altered your microbial flora. And you may be still taking many medications that make your mouth dry, that suppress your immune system. So long-standing antibiotic, long-standing steroid treatment, or other immunosuppressive treatment, and all these can cause your mouth to cause coated tongue or caries tongue. Most important thing is to avoid using any mouthwashes with alcohol in it because that's going to dehydrate more. So only thing that you want to use is basically drink enough water, but salt and baking soda mix in 8 ounces of water. That's the easiest one to rinse your mouth frequently, and we will talk about dry mouth treatment later on. So never, ever use any mouthwashes that have alcohol in it, okay? So this is where I want you to see the difference when a lot of time even your doctors will tell that you have thrush when they see a white area on the tongue. This is coated tongue. This is bacterial coating when you have an excess growth of those filiform papilla. This is not yeast infection. When a yeast infection occurs in GVHD patients or anyone who is immunosuppressed, this is how the tongue would look like, very red, no whitish. Sometimes you may have a little bit of white patches that can be wiped away easily. So this kind of reddish, kind of almost like a bold tongue like that. You won't see this kind of the papillae that feel kind of granular like this area. So when you see that, then you know, and this will be very sensitive, will burn for spicy food or acidic food. So that's how you will differentiate. This is a very frequent mistake patients make, that when they see this white, they think that they have thrush or yeast infection. And even sometimes it get reinforced by the doctor. So I want to highlight this important difference that thrush only occurs in the top of the tongue. When it occurs, it looks like more reddish, not like white like that, what you are used to hear from other areas where white areas. So how do we treat the hairy and coated tongue? This is another common complication I see in patients with chronic GVHD. So there are different oral antimicrobial rinses. One is called chlorhexidine. Unfortunately, they stopped making the alcohol-free one, so still you have alcohol containing. But I'm not going to ask you to rinse your mouth with that, but you pour it in a cup and use these tongue scrapers like that. You can buy it commercially. Dip them in that one, and every time after you brush your teeth, just brush or scrape your tongue with that, okay? That's the best way to kill those bacteria that are coated on the tongue. If some patients, even with that, they don't get better. So sometimes we develop what we call a dark-in solution, which is kind of a diluted Clorox, basically. You can, 1.25%, and you dilute it, and you basically dip the same tongue brush and scrape it. And this basically takes care of all the bacteria. It kills it. So these are the two best ways to kill the bacteria that is growing on your dorsal tongue and causing the coated tongue. Okay? And you can see here in a patient with a very dry mouth, very thick, less watery saliva, so that bacteria gets coated. And I'm just showing a picture here. This is called Delsco we use this. When there is a bacteria, it produces a fluorescence. It looks like a red color. I sometimes use to demonstrate to the patients, this is not an yeast, you have a lot of bacterial coating. That's what it makes it white area. So remember that coated tongue is bacterially, majority of the time is bacterial coating with keratin builds up and other things that cleaning the tongue, brushing the tongue with antimicrobial will take care of that. Okay. The other third complication is the dry mouth, which is some of you might already know that more. And it is mainly caused by two reasons. One, the GVHD, that the immune cells that are grafted to you, the allogenic graft, they can affect your salivary glands and cause a similar disease. We call them Sjögren's syndrome. But where autoimmunity, or that is an autoimmunity in non-GVHD patients, in GVHD patients, basically a Graft-versus-Host disease affecting the salivary glands. So it destroys the glands so that they cannot make spit. So you develop dry mouth. even in the absence of that condition, a lot of patients, well, you are taking a many number of medications, maybe a lot of the medication that starts with antipsychiatric, antipsychotic, anti-inflammatory, number of blood pressure medication. There are a number of medications. One of their side effects is dry mouth. So the medications and the GVHD are the main cause. So we see a higher proportion of patients with GVHD seems to have a dry mouth. So we need to treat initially with conservatively like an over-the-counter medication. If it doesn't get better, we prescribe medication. I'll come back to that in a minute. So, and also the third, not least common, is also anxiety. Because I know you have gone through a lot of other cancer diagnosis, then bone marrow transplant, a lot of medication to take, and that really causes severe anxiety and stress. And that also can cause dry mouth. So you have the medications or Sjogren's syndrome-like effect as well as anxiety. All three of them can combine or even in isolation can cause dry mouth. So and that causes dehydration also because you may not be drinking a lot of water because of the pain or other things. All these factors also add to the severity of the dry mouth. So how does it feel? A lot of patients will say dry mouth, they have to continuously drink water, they have to get up in the nights and drink water. A kind of mouth feel touch, it's kind of almost like a scorch, like a burn, almost sandpaper-like sensation. Tongue and everything sticks, it doesn't move. And in fact, if you have a Lycanoid mucositis or like other condition we just talked about, and they are going to be more worse because your tongue and cheeks are not lost their moisture and they are not a lot of friction, so that get aggravated, so it make a more big and bitter taste, metallic taste. You will have difficulty talking, chewing food, choking especially, and all these are complications that are seen in patients with severe dry mouth. So definitely we have to treat to improve your moist in your mouth, improve your dry, treat that. Okay? So what are the other complications other than this dry mouth causing these that we just talked about? The long-term complications are, in addition to the discomfort we just talked about, it increases the risk of developing decay. And I will show you the type of decay that you see in patients with severe dry mouth. It also increases your gum disease. So decay and gum disease are more higher risk and more severe when you have a dry mouth because saliva protects, it has an immune system. It protects against bacterial infection, even fungal infection. So you have a dry mouth causes gum disease, decay, more frequently yeast infection in your mouth. We are not taking any fungal medication. It's also important to taste food. When you don't have, you may not be able to taste the food or altered taste. And the last not the least, we don't understand it's going to aggravate if you have a mucositis and ulceration because of the friction. Number two, saliva has growth factors. It facilitates the healing of open wounds. And when you have a dry mouth, that function is lost. So you're going to have a persisting sores which are not healing because of the dry mouth. Even though we don't appreciate that, but it's very critical to make more spit so that can help to reduce some of these complications. So how do we treat patients with dry mouth? There are a number of salivary substitutes you might have heard. Many of you know biotin. I do give it to some patients, but there are more than biotin. There are a lot of different products. I may have pictures in a minute. So I will tell you when I show you the pictures. So there are stimulating ones that make you to stimulate, and definitely we can prescribe you medications to make more spit, and they don't have a major side effect. They're very old medication like a pilocarpine that make you to sweat a little bit. Other than that, it's very tolerable by a lot of my patients, so that can help you to make more spit. It also keeps your salivary gland active. If you don't use it, you lose it. Same thing happens if you don't make your salivary gland to work, and they slowly die. So that's another reason to treat you to make your spit, your salivary glands to continuously work, and they become more active. So cavity prevention is basically fluoroflossing and using fluoride prescription gel. I will talk to you in a minute. And sometimes we use varnish, especially to prevent caries. And of course, you have to go to your regular dental care. Some dentists are a little hesitant to treat you, and then you find a dentist who is comfortable treating patients with GVHD, and it's not like any other patients who have immunosuppressed treatment. So there is no contraindication to have fillings or anything like that, or getting your teeth cleaned. As far as your GVHD doctor tell you that you can have dental treatment, you should be able to go to any dental office and get your teeth cleaned, caries protection, fluoride gels. And if you have an yeast infection, of course, we have to treat you for an antifungal infection. Okay. So these are some of the things that I prescribe. These are over-the-counter treatments. You can buy it online or you can buy it from anyone. And a lot of patients use biotin, but there are many, many products available. And I like many of my patients like this product, Xylamelts, and you should get mint-free. There is no flavoring. So this is more like a tablet-like that is stick between your gum and the cheek, and you can put two of both in the bottom or in the top gums and just leave it there. It will stimulate you to make more spit, and it also protects your teeth against cavities. It has xylactin in it. It's not sugary, so it is a lot of my patients likes that. And there is another one, same chemical in that. It's called Sparks. It's a candy-like that you put it in your mouth, let it dissolve, and it also stimulates. It also protects it. You don't need to use both. You can try either one, and whichever the one you like, you can use it. And then you have sprays, and you name it, that are called Saliva Max. There are a number of over-the-counter products. Why do we have many of these? Because it's a personal preference. Some patients like one product, the other patient will come and say, no, I don't like it. So you are the best person to try that. Whichever the ones that works you the best, just stick with that. You don't need to use many of them, but you select one that works for you the best. The other ones that are sometimes prescription ones are the ones that's called Nutracell and Saliva Max, which are basically, they will send it to your home, you mix it, and you dissolve it, you mix it and rinse your mouth frequently. The easiest one is you can also use a half a teaspoon of salt and half a teaspoon of baking soda in 8 ounces of warm water and use that to rinse frequently your mouth or gargle your mouth frequently. These are the other two medications, Cymbeline and Pilocarpine, are the two prescription medications that are currently approved by FDA for dry mouth, which I frequently use in patients with severe dry mouth. As I said, these other ones we just talked about is symptomatic relief only. But these are the two medications which is going to stimulate your salivary glands to make more spit. So what we are doing is we are making the salivary glands to continue to work. If they stop working, they're going to die. So that's another reason that we used to prescribe this medication. If you can tolerate, if there is no major side effects, there is no harm in putting you in that medicine so that your salivary gland is still continuous. As you know, we don't use our muscle, we lose it. The same way salivary glands are not stimulated and they are going to lose and they are going to slowly undergo atrophy. Okay? Again, this is the very common infection I see in patients, especially if you are not on antifungal prophylaxis. So a lot of time patients may have yeast infection, but they may assume that they have GVHD affecting the mouth, Lycanoid mucositis. They can look the same. They can look red and white, painful, burns. So you won't be able to tell, even some of the physicians may not be able to tell whether it's an yeast infection or Lycanoid mucositis. So the first thing I want to find out is if you're not in antifungal prophylaxis, I need to do a brushing or I need to do a scraping to test for an yeast or empirically treat with an antifungal medication to make sure it's not an yeast infection. It's very common because of the dry mouth, some of the immunosuppressed medications. Here is the common way the yeast present. This is the one you might know, these white areas. If you're wearing a dentures, if you don't take it out in the night, when you have a dry mouth and other immunosuppression, you will see red areas underneath the dentures. That is always yeast infection, not denture stomatitis or anything like that, no denture irritation. You always have to take your dentures when you go to sleep, and or like you may have these corners of your mouth will be cracking. That is also commonly caused by yeast infection and crusting and the red areas like that. So it's a very, very common in patients with GVHD. Only if you're taking an antifungal prophylaxis for to prevent like a fluconazole or another thing, then you may not develop that. But otherwise, this is not uncommon that we see. Okay. This is another common thing that we see patients with, not as common as thrush. This is called chylitis. Chylitis means lip inflammation and chapped lips. The patient will say thickening, almost peeling of the skin of the lips. Sometimes they build up a lot thicker. And when you build up a like these thick areas, what it becomes an area for the bacterial or fungal overgrowth. And this is always those surface thick areas are dead tissue sticking to your mucosa because you don't have a lot of saliva, so the lip is very dry, so the dead tissue is sticking more and more, and it becomes an area for overgrowth of bacteria and fungus. So you may be taking, I'm taking yeast medication, I'm taking antibacteria, so that should not be the cause. Even doctors will think like that. But remember, when you have a dead tissue on the lip sitting there, there is no blood flow to the dead tissue. So then your antibiotics that you are taking systemically or antifungal medication you are taking systemically, the blood is the one that brings the medication to the area where it's supposed to work. But if you have a dead tissue, then you are not going to be effective. Those antibiotics will not work. So in order to do that, we have to use some topical antimicrobial creams or antifungal creams so that it can kill the top. Because the dead tissue, your systemic antibiotics and antifungal medication will not work. And I will tell you the common one that we use for these problems. Next slide. So important keep in mind if you are wearing dentures, which can be removed, you always have to take it out when you are going to sleep. If you have a corners of the mouth, basically the other condition that can make you to make dry mouth, like if you're using in addition to dry mouth, if you're using corticosteroid inhalers, poor dental hygiene, all of them increase the risk of developing yeast infection and bacterial infection. So you all have to clean up your dentures, take out the dentures in the night. And a lot of times patients will develop uncontrolled diabetic. These are some of the other causes for developing infection, especially an yeast infection in your mouth. So what are the different ways we treat for yeast infection? There are nystatin oral rinse, which most of you know that. But one thing that I want to make sure that you understand, if you're using nystatin, it's a topical effect. So say if you have a dentures, that's what you are using it underneath the denture, you have red area. If you use the nystatin with the denture, the medicine is not going to work because it's supposed to touch the area where there's infection. So you always have to take your dentures out when you are using that rinse and swallow that medication. Or clotrimazole like a lozenges or torches that you would use. These two, nystatin and clotrimazole, have a topical effect. So this medicine have to touch your skin of your mouth to kill the bacteria, fungal infection. If you have coverage like a denture or something, it won't work. Otherwise, we have to prescribe some systemic medication, which is what the next one is, that is called fluconazole or diflucan, which is what I prefer to use because it's very easy to patients to use, like one tablet, so start with 2 and then once a day for 2 weeks. But we also have to be mindful if you are on one of these medications, like a blood thinners or cholesterol medication or seizure medication or certain blood pressure medications can interact with that. Certain medication you can stop it, like if you are on a cholesterol medication, you can take a 2 weeks breaks. It's not going to make, but you don't want to stop the blood thinners. So you may want to check with your doctors whether any of those medications can be stopped for a short period until you use this medicine. Otherwise, we have to keep you on a nystatin or clotrimazole. So then you have to use more frequently. You have to take your dentures out because those medicines you have to use at least 5 times a day. Okay? The other sometimes make the mistake, again, I don't know how many of you use dentures. Not only you have to treat your mouth when you have an yeast infection, you also have to treat your dentures. Otherwise, after you get cleared by yeast, when you put the denture back, you're going to reinfect. So you always have to treat the backside of your denture with some kind of an antimicrobial substance like such as chlorhexidine, or the best treatment if you have an acrylic denture, that's the pink one like that, not metal dentures. Metallic dentures, you want to use the Peridex or chlorhexidine. But for if you have an acrylic, this pink one, there are two ways you can do. You can do just a household bleach, 1%. Usually the 10% you dilute 1 to 10. And you put that about your denture in that for 10 minutes, and you take an old toothbrush and scrape your dentures, clean it up, and then let the denture sit in a running water for about 2-3 minutes to get rid of all the Clorox, and that will kill everything that grows on the back of the dentures. Or you can even microwave it, put it on that water, and heat it at 800 watts for about 6 minutes. That will kill it. So that's a way you would dent only for acrylic, these pink dentures. If you have a metal dentures, don't try that. For that, you need to use chlorhexidine is the best way to kill those ones. Okay. Dry mouth, as I mentioned, not only causes yeast of all the complications, they even without having like GVHD, if you have a dry mouth, because of the lack of moist, lack of the increased friction, you're going to break up with ulcers in your mouth, even in the absence of a GVHD affecting the mouth. So dry mouth itself can cause ulcerations like that. And when you have a dry mouth, it can get secondarily infected also. Okay. So keep in mind, even in, you don't have a dry GVHD affecting your mouth, but having dry mouth increases the risk of developing ulcers like that. So when ulcers occurs in the tongue, when they go very deep and kill some of those muscles, then these ulcers will not heal because there is dead tissue, and usually it gets secondarily infected bacteria. We have a technical term called traumatic ulcerative granuloma. It's kind of a long term. We call them TUCSI. So it usually occurs in the tongue, in the posterior portion of the tongue, like a deep ulcer, not healing. It can last for months and months, and it can look very similar to a cancer. Because the reason why this ulcer is not healing is, one, there is a lot of dead muscle. You know, the tongue is full of muscle. Under the skin of your tongue, immediately there is underneath this muscle. So if you have accidentally bite on it, or if you have a trauma that goes a little deeper and damage the muscle underneath, the muscle dies. So when there is a dead tissue underneath, it will not allow the wound to heal on its own. So in that case, always we have to go and clean up and basically conservatively do a biopsy to remove the dead tissue. And sometimes if it is secondarily infected, we have to prescribe some antibiotics that, as I said, is a gram-positive. So we have to put you on augmentin or amoxicillin to kill the bacteria, remove the dead tissue so the ulcers can heal. So this is not the Lycanoid ulceration I just talked about. These are basically caused by traumatic ulcer that going too deep, and that can be increased in patients with GVHD due to dry mouth, which we see not infrequently in patients. And unfortunately, sometimes it gets mistaken for GVHD, and it's not. It is actually something that we see in non-GVHD patients because of the non-healing ulcer due to dead tissue underneath, and it needs to be biopsied to make sure there is no cancer, and it is also the biopsy helps to remove the dead tissue and make fresh bleedings to facilitate the healing. Okay. The other ulceration very frequently, 12 minutes left to go. Okay. So you have some ulcers like these ulcers. These are chronic ulcers. When you have a non-healing chronic ulcer, these multiple ulcers, that is typically a cause of herpes infection. I know you may be taking some antiviral medication, and even with that, there are certain viruses can become resistant, and I will know that you are GVHD, and infectious doctor will be speaking about those. So even though you may be on antiviral, still you can develop chronic hepatic ulcers. Unlike non-GVHD patients, these herpes infections will not heal on their own. They will persist. So that's a reason that sometimes you may want to make sure that is either doing a culture test or the biopsy to test whether these ulcers are herpetic infection or not. In that case, they have to change your antiviral medication. I will let your infectious docs speak about the different other options that are available for these medications. So the other non-healing ulcers, always think about chronic herpes ulcers. Okay. Important thing to remember is there's a prevalence of drug-resistant herpes virus are higher in allogenic bone graft patients than non-GVHD or patients who did not have. So there is, even though you may be on valcycloviral, but you can develop chronic herpetic infection. So and your doctors know that, and they will test for it. And in that case, they'll have to prescribe some different medications. So keep that in mind. It doesn't mean you're taking antiviral medication. You cannot have it. Sometimes resistant viral, and especially it's more common among the first carbonated is the one that usually given. It has kidney toxicity. It's beyond my expertise, and the other doctors will talk about that later on. The type of caries that you're going to see in dry mouth are typically around the gum level and also at the top of the front teeth. So it tends to affect your front teeth, and you don't want to lose your front teeth. So important thing to you, make sure that when you develop these dark areas or in the gum level, you see brownish areas, those are decay. So you really need to go to a dentist and get that area filled, because you don't want to go too deep and then you end up needing a root canal, or the teeth, you may lose it. And frequently we see them in the front teeth, and you don't want to lose that. So this type of decay on the top of the teeth and the gum level are always seen in patients with dry mouth. Okay? And an important thing to remember is if you have a dry mouth and this type of decay, please avoid drinking any carbonated water, drinks like a Diet Coke. Even you may think I'm taking Diet Coke. It's not, because any carbonated water is acidic. So it's going to dissolve your enamel and protection. So never, ever drink anything carbonated if you have dry mouth, because that's going to increase your risk of developing caries. Okay? Because the saliva neutralizes everything what we drink. When you have a dry mouth, it won't neutralize. So please do not drink any carbonated water if you have a severe dry mouth. So the cavities occurs in the cementoid, and this is an X-ray. I don't know whether what shows up. Even you may have a crown. You may not even see there is a decay, and then you go after 6 months, 1 year after all your treatments finished, and your dentist take a picture, radiograph and say, oh, you have a lot of decay under your crown. You're going to lose the tooth. Because it always occurs at the margin of the crown and your tooth or cemental junction. That's where the decay occurs when you have a dry mouth. So it's important to keep your mouth moist, prevent caries, and frequently get tested or x-rayed to make sure that you don't develop. So one of the things that you can do to prevent decay when you have a dry mouth is using a fluoride gel, neutral pH. Prevent solid. This is more like a toothpaste. You put in a small amount in your toothbrush and just brush your teeth before you go to bed, and that typically protects against decay, so that your dentist can prescribe. You can do a non-flavored one if you have a dry mouth, so that it doesn't bother your mint. Sometimes can cause burning. This is the other problem that we see in patients with GVHD. So this is gingivitis caused by GVHD, and it's not due to bacteria, and it's something we also see in patients with lichen planus, other autoimmune disease. So we need to treat this inflammation so that you can brush your teeth and dentist. So a lot of time you want to let the dentist know that you have GVHD affecting your gums. That's what keep it, so that they don't blame that you're not brushing your teeth. This inflammation is not caused by bacteria, but your GVHD causing inflammation of the gingiva. And that's what we call them non-bacterial or non-plaque-related gingivitis. So we have to treat similar like GVHD using topical corticosteroids. Okay. So for that, so it is basically a two-way process. When you have a GVHD affecting a gum, you can't brush your teeth. Then you have bacterial builds up, and that makes it worse. So we have to treat the GVHD affecting your gums. At the same time, your dentist have to clean your teeth and you have to brush your teeth. If we leave both of them, it's going to make it worse. Both, you're going to have a GVHD causing inflammation, then bacterial accumulation, build up, and that causing more, and you have a severe periodontal disease. So the way we treat the GVHD affecting a gingiva, that is a gingivitis due to GVHD, is basically we make a sub-tray, a custom tray for your gums, not similar to a bleaching tray. The bleaching tray is mainly to bleach your teeth, but this is to apply medication to your gums. No, we have an area on your skin. You can put a gel or cream, leave it there. In the gums, you cannot do it. It's going to be wiped away by spit. So basically, making this custom tray, then you can put the gel medication inside, and you wear it in touch with the gums. So that keeps the medicine on touch with these areas for 30 minutes. Then you take it out, and 10 minutes later, you rinse your mouth, and do that for 2 to 3 weeks, and that will clear the inflammation of the gums. Then you go to your dentist to get your teeth cleaned. So that's how we manage the gum involvement by GVHD. So we call them medication application trays, that your dentist can make it as a sub-tray to do that. Okay. So always plug. You use a soft brush or a water pick to very gently remove your bacterial plaque. And this is a very common, another complication, not as common as the other ones we talked about. These are small blisters showing up on your roof of your mouth, especially at the junction of the posterior part of the roof of the mouth. These are typically occurs just before you eat or even while eating. They breaks up and releases some fluid. Sometimes during that time it may be a little sore, and it's very benign condition. You don't really, unless it's very bothersome, we don't just leave it, just let you know. These are called superficial mucocele because those salivary glands in that area get blocked up by this keratin buildup. So that what causes these blisters to form up, especially when you're eating, the saliva is trying to come out, but this keratin blocks it. So that's what it just swells up like a blister, and it breaks up and produces a little soreness. It's something we see them in patients with GVHD. These are called superficial mucocele. The last, not the least, is the cancer that occurs in the mouth. It increases in patients with GVHD, have a higher risk than a general population. But the most common problem that we encounter is patients, sometimes even doctors, may mistake when you have a non-healing ulcer with red area, they may take out, you have GVHD. Patient might have a GVHD. This is what many of my patients who have developed cancer in the mouth, initially they assumed they had GVHD. Oh, I have to put up with that. I don't have to, there is no treatment. I'll have to keep up with that. Don't do that. At least go and see somebody who knows what this GVHD would look like, how the cancer would look like, how his herpes will look like, because that way you won't miss the cancer. Because cancer, chronic traumatic ulcer, GVHD, all can look very same in the mouth, not only for the patient, but also for the clinician who are not used to seeing mouth problems. So whenever you have an ulcer that doesn't heal, see an expert clinician who knows mouth diseases. They can look at it and say whether you need a biopsy or whether you have a herpes infection or you have a tuxi or is it really a GVHD causing the problem. That's the last but the most important message I want to convey, that do not assume everything in your mouth is GVHD, because sometimes the other bad ones can show up like similar to GVHD. Okay? So definitely you have to go and see your dentist or oral medicine doctors or expert in oral diseases, and periodic biopsies. There's no harm in doing the biopsy when in doubt. Whenever you have an ulcer that's not healing on its own after the treatment, that is a danger sign in the mouth that needs to be further worked out. Okay? So there are different ways we can do an oral cancer screening. This is for general population as well. So there are ways that you can use the lights and things like that. That's not very critical. So at this stage, I'm going to stop and answer your questions.
Thank you, Dr. Vigneswaran, for that very excellent presentation. We are now going to go to the questions. We will get to as many as we can, and those that are not answered, Dr. Vigneswaran said he would be happy to answer, and we can get you those answers. The first question is, I have many episodes of multiple canker sores. I just started having these after my unrelated donor transplant. Could this be a form of GVHD? What kind of doctor can treat this?
Okay, that's a very good question. You remember, canker sores, or we call them aphthous, rarely occurs if you don't have a history of previous canker sores, and always occurs in younger kids, okay? So a lot of patients, we assume when you have an ulcer, you use the term canker sores, and when you tell to the doctors, they might also think. Never, ever think that ulcers occurring in after 30 or 40 years are not canker sores. They are either GVHD or medication drugs can cause ulcers, or like as I said, herpes, or this tuxi or dry mouth can cause ulcers. They are not really canker sores. Canker sores are typically, you see them in high school kids, young, healthy patients. They develop and they heal on their own. The other important thing is canker sores don't persist. They usually heal within 2 weeks' time. If you have an ulcer that doesn't heal with 3 weeks, that's not a canker sores. Okay, so those are chronic ulcers, and there can be GVHD affecting your mouth, or it can be chronic herpes, or it can be tuxi, a traumatic ulcer, the long nerve I mentioned, or a very rare case of it can be also cancer. So definitely, the doctors are basically oral medicine doctors are the ones who oral pathology, oral medicine, or there are some larger centers will have expert GVHD doctors who manages oral problems. So you want to look at, I know we have a long list of doctors listed in those Infonet area that you can find it, that I work at MD Anderson, and I see, but you can, and most of the academic institution going to have expert who can manage these conditions in the mouth. Okay?
Thank you. Next question. I have mouth GVHD and recently very tight lips. Any advice for relief? I'm using hydrocortisone 25 milligrams, 5 grams, but not much improvement.
Yeah. The time, which I just forgot to mention, that the tight lips and even the mouth can become kind of a opening of the trismus, and these are some of the other complications. We see them, even though rare, that is due to fibrosis, because that also make your GVHD. It's not scleroderma-like, but it's kind of mimic like that. Your skin doctors will talk about mostly when your skin becomes very firm and it's not flexible. The same thing, the skin and the lip can happen. A lot of fibrosis can happen in your cheek as well as on your lips. That makes the mouth opening harder, lips become more stiff or something like that. Even the topical steroids can help, because that's the only way we are going to reduce the inflammation and fibrosis. But sometimes when you put too often steroid on your skin of your lips, that causes atrophy of the skin. So you're making it worse. So occasionally I give a steroid injection deep into that area to kind of relieve the inflammation inside that deeper tissue. Rather than putting a topical, because as I said, when you have a keratin buildup or fibrosis, the topicals won't penetrate. So sometimes we do use a steroid injection to do that, and if there is too much stiffness, or otherwise the same, it's kind of a similar problem some of you might have experienced on your skin, or your skin specialist will talk about more like a scleroderma-like skin changes that happens in GVHD. Same thing can happen in the cheek that makes the mouth opening harder, and the same thing can happen on the lips skin that makes the skin to be fibrotic. We don't have a lot of good treatment for that, unfortunately.
Okay.
But steroid injection is the best option.
Next question. I have heard that some medications for osteoporosis, such as Fosamax, have negative side effects for the bones in the jaw and the mouth. Is there any truth to this?
Yes, 100% truth. Yes, that's a very, very good question. So I know that most of you are on a long-term steroids and everything. You're going to have a higher risk of developing osteoporosis. So again, your doctors are going to say you need to take Fosamax or the other newer medications. So what it does is it makes your bone remodeling, it delays your remodeling. The other bones are not a problem. Sometimes you may get a femoral fracture, but otherwise those bones. But in the jaw bones are continuously, we have decay going in there, infection, gum infection or anything, or they take a tooth out, the bone heals by remodeling. But when you put the patient on these medication, the remodeling of the bone, regeneration of the boning is not effective, or it basically. So it get infected, the bone dies because of medication-related osteonecrosis. So how do we prevent? Your doctor's going to determine you really need to take this medication to prevent you losing bone. You still have to take it. But there are prevention you can do. That's what we just talked about. Because you have a higher risk of developing gum disease, you have a higher risk of developing decay. So the best option is to prevention. You don't develop decay by cleaning your teeth, checking up frequently, using fluoride, gum, getting teeth clean, and if you have GVHD affecting your gums, treat that with the topical steroid with the medication application tray. As far as you don't do any invasive treatment in your jaw bones, then you won't develop it. So the most important thing is preventing infections going into the jawbone, either from the teeth or from the gum. Or you don't need to have a tooth extraction. That is the worst part. So if you don't need to have those problems, then you don't need to worry about it. But if your doctor is telling you may or may not need, if you have a GVHD, I would recommend avoiding that. But I will let your doctors to decide whether you need it or not. If it's my mother or my sister, she has GVHD. If you have a borderline osteoporosis, I would say don't take it. Okay.
Thank you. Next question. Is there a correlation between high-dose chemo ahead of an auto transplant and teeth crumbling or disintegrating 5 to 10 years later?
Not directly, because the teeth, when they're formed and when the teeth are erupted, they are whatever the treatment you do, because the enamel and dentin are mostly formed already, any medication they use or anything that's not going to affect your teeth. Teeth, unlike bone, doesn't remodel. Okay, so that's why we can't treat the teeth like giving more hormones or anything like that. Teeth are formed and they're going to stay. The enamel is permanently deposited. But when you have a dry mouth, and you drink a lot of Cokes and a lot of carbonated drinks, they can remove some of the enamel and make the teeth to be more fragile. So the most important thing is keeping the moist, dry mouth, and preventing decay by using the fluoride, and most importantly, avoiding any acidic drink in your mouth, including wine.
Okay, thank you. Next question. Does the use of baking soda-based mouthwashes daily cause any problem with the enamel breaking down or tooth decalcification?
Very good question. That's the opposite. The enamel is breaking down by acid. Bicarbonate, I know we are going to the high school chemistry, bicarbonate is alkaline. So the reason we use salt and bicarbonate to neutralize the acid. So it is how do we get acid in the mouth? Bacteria make the acid. Drinks makes that acid. So there are many different things that can make your mouth feeling acidic. So the bicarbonate is basically neutralized. And in fact, saliva has a lot of bicarbonate. That's why the saliva is important for neutralizing. Since we have a dry mouth, we use the sodium bicarbonate, that is the baking soda, with salt. An excellent question. The opposite. It actually neutralizes so that your enamels are not going to be dissolved.
Okay, I think we have time for one or two more questions. The next one is, how should I replace saliva? My tongue is all white and sometimes is painful and irritated by food. How can that be improved?
Yes, that's a good question. I know you can go through this handout, and I've sort of a lot of pictures in there. Some of the over-the-counter one, you can order it, Xylem Melt, or Sparks is my patients like that. It also protects your teeth. You can try that on your own. You don't need a prescription for that. And also salt and baking soda, the mixing it out, or there's called Nutrasal or Saliva Max that your doctors can order. But if you have a very severe dry mouth, I would definitely ask your doctor to prescribe the medication that's going to make you to make more spit. That is pilocarpine or Similine or Saligen. And they have very limited, very minimal side effects. And as I mentioned, we're using that. It is making your it stimulates. It's a parasympathetic. It makes the salivary gland to go over dry. So if they are sleeping, they're going to wake them up and going to start making more spit. Again, a lot of time you wait too long, then the salivary glands are dead. You have never had radiation. Some of you might, but they are usually not in the head and neck area. That's where your salivary glands are. So important thing is to start the treatment early so the salivary glands are not dead. If they are dead or if they are what we call an atrophic, then you can't help by giving those medications. But if you started early with the severe dry mouth, then definitely those medications will work. And if when you are taking it, you get side effects, then you want to stop it, and then you will use the other ones that I just mentioned about. There are number of different over-the-counter, and as I said, you want to try different ones and pick up one. And especially for the soreness and pain, make sure that you don't have an yeast infection. You are taking antifungal medication, and definitely make sure that you don't have a GVHD affecting your mouth. If that, then we need to treat for that. So those are the major reasons for being pain, especially on the dorsal, on the tongue, or whenever you eat spicy food or acidic food, it burns, you have inflammation in your mouth. Okay? A lot of my patients will say, I avoid spicy food. No, I say, eat it. That's the way you're going to find out you have a problem or not. So spicy food doesn't make your GVHD to get worse. It only tells you you have inflammation in your mouth. Okay?
Well, that's going to have to be our last question. On behalf of BMT InfoNet and our partners, I'd like to thank you, Dr. Vigneswaran, for your very helpful remarks, and thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way, and enjoy the rest of the symposium.